Good afternoon. My name is Dorothy Burridge, and I'm the Regional Education Coordinator with the Central East Stroke Network. And I'd like to welcome you to our webinar today, The Benefits of Early Detection in the Context of Dysphagia Screening Related to Stroke, a Canadian Success Story. Before I turn it over to our presenter, I would just like to remind you that you are welcome to submit questions by typing them into the question section of your control panel. And we will have some time at the end of this presentation to answer those questions. So it's my pleasure to introduce Dr. Rosemary Martino today. She is a professor in the Department of Speech Language Pathology at the University of Toronto, with combined expertise in dysphagia and clinical epidemiology. She has practiced as an SLP for 15 years and now holds a prestigious Canada Research Chair, Tier 2, in swallowing disorders. She is also a fellow of the American Speech and Hearing Association, and she served as president of the Dysphagia Research Society in 2011-12. The main focus of Dr. Martino's research is oropharyngeal dysphagia, secondary to head and neck cancer, and stroke, leading several multi-site trials focused on early identification and longitudinal surveillance of dysphagia. She has developed 2 dysphagia-related tools, one called the TORBEST for early detection of dysphagia, particularly in the stroke population, and the other called the MAUD to measure medical consequences of dysphagia. She has published 1 copyright, 76 peer-reviewed publications, 6 books, monographs, 5 book chapters, and delivered over 130 invited talks. Her work has directly informed dysphagia clinical guidelines, and as a principal investigator, she has obtained 33 grants totaling over 15 million. So it's my pleasure to welcome Dr. Martino, and I will turn the presentation over to you.
Thanks, Dorothy, and welcome to everybody who's made it to the call today. I'm really excited to have an hour with you today. And Dorothy, I just saw the monitor here, the camera just came on. So I just have to reposition things so I can see things. Anyway, as I was saying, thank you very much for the invitation. I'm quite excited about being able to speak to you about dysphagia and stroke today. And yes, a Canadian success story that many of you perhaps in the audience have been part of this, so I'm going to be able to give feature and highlight to that. I'm coming to you from Toronto, so there's a picture in front of you there of Toronto. You can see the CN Tower there in the background. This is the University of Toronto, which is sort of my home when I'm working at the office, but right now I'm coming in from home. And the hospital is just here in this corridor as well, which is also where we do a lot of our research. So let me just get repositioned here. Fantastic. Okay. So these are my disclosures. The key points that I'm going to address today are listed here on this slide, and they're going to focus on early identification is a game of probabilities with high risk stakes. I'm going to focus on the Canadian standards and how Canada has really led the way in dysphagia and stroke, and talk a bit about the benefit and the power behind the bedside dysphagia screen. And then a little nod to the future on where to go to next. So the first, early identification is a game of probabilities with a high risk stakes. So you can see here a little cartoon to start us off, that the whole process of diagnosis is really a game of probabilities. In this case here, this gentleman, the doctor is saying to the patient offhand, I'd say you're suffering from an arrow through your head, but just to play it safe, I'm ordering a bunch of tests. And they really highlights, even in this case, perhaps kind of obvious, but the value that we in the medical field, we place on tests. So diagnostic probabilities really are when we order a test, we're really trying to address the uncertainty in our clinical practice, and really every clinical encounter that we have has some kind of uncertainty that we're trying to diagnose and resolve. So as clinicians, our job is to somehow overcome these uncertainties and make accurate diagnoses. And to do so, we need tools. We need tools that are reliable, that are feasible, and that are valid. And the accuracy of the diagnoses that we can generate really depends on these tools, and the accuracy of our diagnoses will then impact the appropriateness of the treatment that we then prescribe to our patients. So better decisions require better diagnostic tools. They're really the core to ensuring that our practice is of the highest quality. And when we're dealing with the field of dysphagia and our practice of dysphagia, having a misdiagnosis of dysphagia or a missed dysphagia in a patient can cause serious consequences, and that's where the high stakes comes in for me. Missing something that has no consequences to a patient can be forgiven and perhaps can be detected in, in another visit, another patient visit, or perhaps another patient encounter. But when you miss dysphagia, it can have serious consequences, including death. And let me show you some empirical evidence for that. This is data summarized from a large US national adult inpatient sample of thousands of patients. This was collected from 2009 to 2013. And these patients are all inpatients and of mixed diagnoses, so not only stroke. And I'm sorry that the lines are a bit faint, but it's an important data set, and it's a really fantastic article if you're looking to read something cutting edge and really useful for us as clinicians. What it shows is that inpatients, regardless of etiology, those inpatients with dysphagia are at higher risk of length of stay. Patients with dysphagia versus those without had longer length of stay, total healthcare costs, including medications as well as personnel, and certainly care costs. A subgroup of that was also more for those patients with dysphagia. And the bottom line, inpatients with dysphagia were more likely to die, so a higher mortality rate compared to patients who are otherwise similar but don't have dysphagia. So, this is coming from an American data set, but I would hypothesize quite comfortably that these findings generalize to the Canadian landscape of our inpatient caseload. And what was, I guess, interesting in the previous slide, which I just will iterate now, in the general inpatient population, regardless of etiology, the prevalence of dysphagia was about 3% based on that data. But now, moving to the next slide, if we intensify the situation and really focus on inpatients with acute stroke, things get a little worse with regards to dysphagia. We have patients now who have reduced sensation, who have cranial nerve abnormalities, and so their sensations such as taste, smell, and tactile sensations are reduced or perhaps even absent. They might have reduced salivary flow. Patients with stroke and a neurological disease will have skeletal and muscle changes that reduce the range of muscle movement, the strength of those movements, all of which are going to impact the way that patients are able to move a bolus, be it a liquid or food, through the oral cavity and through the pharynx, and move that bolus safely and efficiently into the esophagus and not misdirect it into the airway or to leave any of the bolus behind after the swallow. So stroke increases the likelihood of a dysphagia, and in fact, in research that we did in our lab, the incidence of dysphagia and stroke increases quite dramatically from the general inpatient population. The incidence of dysphagia and stroke is about 60%. So 60% of all acute stroke patients who get admitted to hospital will have some level of dysphagia. It might not be severe, it could be mild, but some level of dysphagia. So it's prevalent in the stroke population. What we also found in our research was that not only is dysphagia common in the stroke population, but it also has really serious consequences, similar to the general inpatient study that we saw a few slides back, but perhaps even more magnified of a consequence. In patients with stroke who were admitted to acute hospital, stroke patients with dysphagia had a 3 times greater likelihood of having pneumonia than stroke patients without dysphagia. So this is quite a significant complication related to stroke and dysphagia. And this is a slide I show quite a bit. Is a dose response to this incidence of pneumonia or the increased risk of pneumonia. Here we had, in this sample, we had patients who had aspiration on video fluoroscopy, so suggesting that the dysphagia that they had was more severe, whereas than the previous slide. So these are only patients with really severe dysphagia, and their risk for getting pneumonia increased to 11 times greater than other stroke patients. So you see that dysphagia is prevalent in the stroke population. 60% of patients with stroke have dysphagia. It can cause pneumonia, increases the likelihood of pneumonia by 3-fold. And if the dysphagia is severe, it increases the risk for pneumonia even more so, to 11-fold. So knowing these increased risks of especially pneumonia really implores us as clinicians to have the tools, to demand that the tools are in place that identify dysphagia accurately so that we can overcome the diagnostic uncertainty, so that when we conduct these tools and these tests with our patients with stroke, we can trust the results of these tools to give us a true answer, an accurate answer, if the patient has dysphagia or not. And so I will continue my theme throughout my talk today, that good tools will actually minimize the stakes of an unnecessary poor health consequence, such as pneumonia or even death in our patients with stroke and dysphagia. And I'm going to give you some evidence that got accepted just last week from our lab that proves that. So, identifying dysphagia risk is great. It's very important, and epidemiological evidence such as that from our lab and that from others as well has identified that dysphagia is highly likely in the patients, in our patients with stroke. But how to best find these patients? So what are the tools? So no doubt, hands down, in an ideal world, all patients who come into our hospital who have diseases like stroke that places them at high risk for having dysphagia, in an ideal world, all those patients would be assessed using a standardized bedside or instrumental assessment with video fluoroscopy or FEES by a dysphagia expert such as yourself, a speech-language pathologist. But we don't live in an ideal world. I think we all recognize that. The healthcare systems that we have limited resources, which means that it's just not feasible for all patients to be assessed with a comprehensive and expensive diagnostic procedure that requires time from a professional group like speech-language pathologists, which we are limited in number, and also procedures like video fluoroscopy, which are also limited to have access to. So we need to go to the next best scenario. So just want to highlight that this isn't the ideal scenario, but it's really probably the most realistic scenario in the reality of our healthcare situation, which is to identify those patients who are at risk of having a dysphagia in these high-risk groups like stroke, using something that is simple, that is less invasive, less costly, less time consumption, requires shorter in duration, but yet it still is accurate to be able to identify this increased risk of having a dysphagia. And that is a screen, a clinical screen that is administered at the bedside. The I mean, a clinical screen administered at the bedside to patients whom we know are at high risk. This is really nice work that one of my doctoral students, Heather Flowers, who's now a tenured or faculty at Ottawa University in the Department of Speech Language Pathology, she did beautiful work where she looked at lesions of patients who had stroke and compared those lesions in stroke patients with dysphagia versus those patients without dysphagia. And what she was able to do was and then look at their MRI data. And what her modeling was able to show was and quantify the increased risk of having dysphagia in patients depending on where the site of the lesion is. She also looked at volume and various other parameters, but with regards to where in the brain there's more likely to have dysphagia, she identified the insula, the midbrain, and the medulla. Some of those we would have predicted as well, but I think it was confirmation to have some quantifiable numbers of the increased odds of patients having lesions in these parts of the brain and then likelihood of having dysphagia. So that data alone, just reviewing the chart and reviewing the MRI data that our patients have, we have a good sense of those, if that stroke patient is likely part of that 60% that's going to have a dysphagia, but it's not enough. You need to be able to have some kind of bedside test in order to be able to confirm the presence of increased risk for dysphagia. So this is sort of my working hypothesis, if you will, which has really driven a lot of my research primarily early on in stroke, which is now, I think it's about 20 years that I've been doing this in stroke. But it's also this hypothesis really kind of informs all my research. I'm doing some work in head and neck cancer right now, and this is sort of the premise of what I'm always sort of keeping in mind when I design a study. And the point here is that screening, if we're going to be implementing screening within a clinical care program, it has to be of value. And for screening to be of value, at the end of the day, it has to be able to show and be proven to decrease the poor outcomes in our patients, decrease the likelihood of pneumonia, decrease the likelihood of malnutrition, dehydration, mortality, cost, many other outcomes that we could add to here. But any screen will not be this beneficial. So a screen also has to be accurate and has to be able to, with good probability, detect the presence of dysphagia. And it needs to have the follow-up of the dysphagia expert. A screen alone identifying dysphagia isn't going to change a health outcome. A screen, though, that can trigger the intervention of an expert, such as yourselves, a speech language pathologist, who can come in and then assess the patient who failed screening with either a diagnostic or bedside procedure, whatever the expert feels is necessary, and then able, from that comprehensive testing by the speech language pathologist, then prescribe the appropriate treatment for that patient. That sequence of events from screening to diagnostic workup by the dysphagia expert, SLP, to treatment, that whole package is what's going to change the health outcome of patients. So we just have to keep in mind, it's not just one element, it's a series of steps. So the whole concept of identifying dysphagia has been very well studied. We started in this space back in here's my first paper here listed on this slide. In 2000 was the first paper that I published. It was early days when I was just starting to think about doing a PhD. I just enrolled into a PhD program and decided that because not much had been done up until then, that I was going to focus my research in the area that I was practicing clinically, which was stroke, and that was to develop a dysphagia screening tool because it hadn't been developed up until then. But the momentum has really, really built, and there's been a ton, and that's probably an understatement, there's been a lot of screening tools that have been published. In fact, last count, there were 35 screening tools that were for dysphagia in stroke that were somewhere available, not necessarily all well validated, all well developed, but somewhere on a list of what was available. And there have been several systematic reviews that have looked at all these tools to evaluate them and compare them for the psychometric properties that they have. In other words, are they reliable? Have they been proven to be accurate in detecting dysphagia? And these systematic reviews seem to generate the same answer over and over again, that the TORBEST, the tool that we developed, and I'll talk to you a little bit about in a few slides, ranks really high with regards to the rigor of its development and the accuracy that it affords the clinician who administers it. But what's important is that these tools are not all built the same, and I think you can perceive that based on some of the comments I've just said, but they also aren't set up, these studies aren't set up to identify the same outcome. For the TORBEST, we wanted a screening tool that identified dysphagia with or without aspiration. We wanted a tool that would identify mild dysphagia, moderate dysphagia, or severe dysphagia, which likely includes aspiration on an instrumental procedure. But some of these tools that have been reported, if you look carefully at their methodology, are really looking for the accuracy in detecting only aspiration versus lack of efficiency or other types of dysphagia, more mild dysphagia. And I'm not going to go into the statistics right now, but the ability of a screening tool to identify dysphagia is much easier than to be able to identify a milder dysphagia. So those statistics, if you will prove that screening tool to identify dysphagia as being quite accurate, when indeed, I think as clinicians, we want to have a tool that identifies more than just dysphagia. So word of caution when you're looking at other tools, and to look for points like that. So this early identification in the slides that we just reviewed is important, especially in the area of dysphagia, because if it's missed, the stakes are high. Patients are going to have more likelihood of bad outcomes like pneumonia, like death, and various other things. So having concluded that, let's now turn to the Canadian standards and showcase how we as Canadians have really led the way in dysphagia in stroke. So this goes back now to 1999, so really far back. I was not finished my PhD. I haven't even thought about doing a PhD at this point, but I was practicing in stroke, and there was a real momentum and movement in Ontario, especially, to set up a center of excellence for stroke. And it became a national movement, which was able to garner a lot of federal money and provincial money to really support the improvement of the stroke service, not just dysphagia, but all of the stroke service. It led to, in 2000, a stroke registry, so patients in Ontario, and I believe Alberta was the next, and then for a period, all of Canada, patients who were coming into hospitals with a diagnosis of stroke were being entered into a stroke registry, which is a fantastic resource for analysis and study. And also what was really great at this early time was in 2002, we as a group of speech-language pathologists, along with other colleagues like nurses and physicians and hospital administrators and various other people, came together as a consensus to develop guidelines for dysphagia in stroke, and they were published in the year 2002. These really picked up momentum, and over the years they were renewed, more recently 2016, and then 2018, so more recently, every 2 years, these guidelines are renewed, and new evidence to support the guidelines gets added to these guidelines. And I'm sure all of you are well aware of these guidelines, and they've been incredibly useful. I'm bringing this up not because I don't think you're aware of them, because I believe as Canadians, SLPs practicing in Ontario, we use these guidelines a lot. But I don't know if we all appreciate that we were the first really with the guidelines on a global level. So I just want to give you a little bit of a boost to make you feel good about that. The guidelines specific to dysphagia are, this is the link for that, and as I said, they get updated on a regular basis as new evidence gets identified. But the core of these guidelines are these 3 points that I'm going to highlight now. So that patients should have their swallowing ability screened using a simple, valid, and reliable bedside test protocol before they take anything by mouth, be it meds, fluids, or food. Again, the next point is patients who are not alert should be monitored and clearly not eligible to be screened, because these are patients who are not ready and eligible to take anything by mouth. So really, as soon as a patient is brought into hospital with a diagnosis of stroke and they're ready to be given something by mouth, that's the critical window of when screening should happen. And patients presenting with any kind of dysphagia, i.e. fail a screening test, then they need to be referred for a full clinical assessment of their swallowing ability to a speech-language pathologist. And it's the speech-language pathologist after that assessment that will determine on the ability and the safety of this patient to be able to continue on an oral diet, and then further pursue with the swallow assessment or make recommendations. But then it's in the hands of the SLP expert. So that's really a simple version of the guidelines. So admittedly, I was one of the prime catalysts for this national push, as I was at that time practicing in the area of stroke and knew firsthand the need for early identification in this patient group. This quite naturally led to our hospital's effort to develop a standardized tool by which to screen for dysphagia early in patients with stroke. The tool that we developed was called the TORBEST. Specifically, speech-language pathologists, as part of this program, the TORBEST program, train healthcare professionals on how to screen for dysphagia using the TORBEST. This training starts first with the offer of a didactic course. It's a program that we developed as part of our research. We have standardized slides that we offer to the speech-language pathologist, who then runs this course. It's a 4-hour course, and the tool itself requires a glass of water, a teaspoon, and the form that we've also standardized. That's all that's really required to execute this tool. I would like to say too that in addition to the didactic training that the speech-language pathologist does, which is a 4-hour live training, there's also a competency demonstration. The new screener, who's freshly trained by the speech-language pathologist, has an opportunity to demonstrate their execution of the TORBEST and their scoring of the TORBEST with a live patient. And that demonstration of competency at the bedside is what then finalizes the TORBEST screener training. Our psychometric validation study proved that this tool, the TORBEST, offers a reliable and accurate method by which to identify stroke patients with dysphagia in not only the acute, but also in the rehabilitation setting. The TORBEST had reliability of 92% accuracy, and accuracy as high as 91.3% in both the acute and the rehab. And in the acute center, it even performed even more accurately with 96%. So 96% of the patients who had dysphagia and stroke were correctly identified using this tool. So with this data, we published this data, we then had confidence that the TORBEST really will miss few patients, if any, stroke patients with dysphagia. So it gave us the motivation and the confidence to introduce it to the clinical community, because because of this accuracy, we knew that the tool would introduce efficiency in the system, and by that I mean that the speech-language pathologists then do not have to assess all newly admitted stroke patients, but only those with a positive test on a TORBEST, and do that with some assurance that very few stroke patients with dysphagia will be missed in this system. So the TORBEST really addresses the diagnostic probability that we were talking at the very early of this talk. You know, the clinical uncertainty that we all battle with as clinicians when we assess our patients. Do they have dysphagia or do they not? So it directly addresses this issue of uncertainty because it's a reliable and accurate tool to detect dysphagia in stroke. One of the questions that we often get asked by our screeners, and I know speech language pathologists have to root back to me often and ask, how do I respond to screeners who ask me this? So we did a deep dive into the data that we had and ran a secondary analysis to determine if indeed the question of do we need to include 10 teaspoons when we do our screening with the TORBEST. We wanted to confirm that indeed 10 teaspoons were necessary. Now remember, the protocol here is the screener administers 1 teaspoon at a time up until 10 teaspoons until the patient has some kind of an abnormal response, be it a cough or a choke with following any 1 teaspoon. With the presence of an abnormal response, the screener is trained to terminate the TORBEST and therefore not administer any more teaspoons and fail the patient and refer on to a speech language pathologist for a more comprehensive assessment. But should a patient not fail, then the screener is trained and to go to 10 teaspoons, not to stop early. And we wanted to confirm that indeed 10 teaspoons were necessary. So as I said, we ran this secondary analysis, and what we found was a definitive yes. 10 teaspoons for patients who don't show any abnormal signs on any of the teaspoons are necessary in order to be able to determine with certainty that the patient doesn't have dysphagia. If they don't present with a problem within the first 10 teaspoons, then the likelihood, high likelihood, is that they don't have swallowing problems. And let me show you a closer image of this graph. So these are, the x-axis are the number of teaspoons, and the y-axis is the accuracy. The higher, the 100% would be 100% accurate. So what you see after 1 teaspoon, very low accuracy. After 2 teaspoons, again, not sufficient accuracy. It's at less than 50% accurate. 3, 4, 5, we get to 5, and we're only at about 80% accurate. Not good enough when we're dealing with a high stakes disorder like dysphagia, that if it's missed, we can have complications like pneumonia and what we saw earlier in the evidence that I was talking about, mortality. So if we can carry that over to 8 teaspoons, we get 92% accuracy. Not bad, but look what happens when we move over to 90, when we add the extra 2 teaspoons and we go to 10, we get 96% accuracy. So we really advocate, and this data supports that position, that screeners need to go to 10 teaspoons and not stop early unless the patient has an abnormal finding. So really important information to relay in the training. So the TORBEST has taken on more than one trial, and this is perhaps part of the success story, because I have practiced as a clinician for 15 years before I went back to do my PhD, and now mainly focused in clinical research at the bedside, but as a researcher, not as a clinician. I collaborate very extensively in pretty much all my studies with speech language pathologists, the clinical community who is in the current, on the ground, and knows the current issues. So this is a study where we wanted to explore whether there was skill delay. Once the speech language pathologist trained screeners with this 4-hour didactic training, did the screeners lose that ability to screen accurately over time, very similar to a CPR kind of training model. And so we had a study that was funded by the Provincial Heart and Stroke Group, and this was a skill maintenance for the TORBEST using a web-based refresher training after the screeners had been trained by a speech language pathologist. And we were quite excited. We got several sites interested. So in Alberta, we had Edmonton and Calgary join this study. And in Ontario, we had one site, and this was Brenda from Midland Penetanguishene. I don't know if she was part of your group, but I think she's since retired, who was amazing in this, in rolling out this study for us. And her site was part of this. And then we had one site in New York State that was also part of this study. And as I said, this was we offered half of the participants, the screeners that participated, access to this web refresher site, which we developed. And some of you might have been part of the testing of this particular site at various points. And this is just a screenshot of that website. What this website offered was independent practice by this trained screeners to go online whenever they wished, whenever they had time, to score patients who were administered the Torbest and were captured on video. They got feedback on their accuracy, and so that we felt was an opportunity for them to refresh and hone on their accuracy skills. So the study design, as I said, was a randomized controlled trial. And sorry, I just jumped ahead here. It was a randomized controlled trial where we included screeners. Some screeners had previous training by a speech language pathologist many years past. But regardless of their training in the past, we provided everybody new training so that we made sure that when they started the trial and were randomized to receive web-based practice or not, everybody was at the same level of accuracy. And we tested that. Once all the screeners were performing very highly accurately on the Torbest, then we randomized them to, as I said, 2 groups, the web access group and no access group. And then we followed them over time for 36 weeks, about 9 months. And we tested them periodically across this time to see if there was any point in which the skill worsened. And to our surprise, we found that there was no skill decay at all. There was good maintenance in both the groups that had web access and the group that had no web access. And you see here that when we tested the groups at around 9 months after, using the same protocol of testing, there was no difference. They all performed, I'm sorry, I might get a little happy here with my button. They all performed really high in their accuracy skills. So this is what we would call a negative trial, where we found no difference between the control group or the intervention group. So really good news. I don't know what happens after the 9 months or almost a year, because there were some patients, some of these applicants were slightly more than 36 weeks at the end. So perhaps there is skill decay after that, but within this period of time, we are pretty sure there's no decay in the skill, which speaks highly to the ability of our SLPs, the community who are training the screeners and training them really well. What was interesting in this study, we did another little dive like I did in previous studies, where I looked at some secondary data that we hadn't planned on looking, but was available to us. To answer a question that, again, we get asked a lot, do the screeners really need the 4-hour training by a speech language pathologist in order to perform at such a high accuracy level? And we never really tested screeners without the training before. We just assumed, we just trained everybody and then tested how accurate they were after the SLP training. But here, this study, because of the design, we actually had this opportunity. So we went back to our data and we looked at the score of the screening accuracy with the Torbest between 2 groups before they were randomized. That's that smaller group, admittedly, who never had speech language pathology training before, and the group that had speech language pathology training, but it was maybe a year or 2 before. And we compared what their baseline score was on their accuracy of administering the Torbest. And we saw a difference, and it was a significant difference. We saw that those screeners who had no training by speech-language pathology performed with only 75% accuracy. And those with the SLP training performed with 91% accuracy. So what this really concluded at the end of the day was that, yes, speech-language pathology training was necessary. It made the screeners much more accurate in their performance on the Torbest, and therefore we were able to advocate that it was a necessary part of the Torbest implementation. Now, those of you who've been part of our course know that there's much more that a speech-language pathologist does than train. Training is the important piece, but there's also the mentoring that happens after that training. That training really positions the speech-language pathologist in our mind to be a mentor of dysphagia and to be available as a resource for the rest of the team, especially those that are trained. So SLP training proved to be very beneficial in increasing the accuracy of the Torbest. But just to address the point that I was just making, that I really feel that the speech-language pathologist is the success story behind the Torbest. I mean, the tool accuracy is good, and I'm glad and I'm proud that our team developed that, but it's the implementation piece that makes this work. And this study really showed that. This was a study where we implemented the Torbest in, this was actually in long-term care nursing homes, where we implemented the Torbest at one point with a speech-language pathologist who was the designated mentor in these long-term care homes. They were private and public, several long-term care homes. And this speech-language pathologist wasn't on site 100% of the time, but was the designate speech-language pathologist who trained the screeners and then went on site periodically to mentor and just to check to see how much of adherence the screeners were, if they were implementing the Torbest with all eligible patients. And we also, that was the intervention, the speech-language pathologist providing the training and then providing mentorship on a regular basis throughout the year. We also, though, interviewed those screeners over the period of a year, about every couple of months, to get their impression and their opinion of their perceived value of the screening tool, the Torbest, and how it really worked or didn't work within their space, within their workspace. So when we started the program, there was a lot of positive feedback here, and the speech-language pathologist I would want to shout out was Becky French, who did an amazing job at this with the study. So the screeners that she trained right after her training were really pumped up and had such positive enthusiasm that they were going to implement screening. And when you looked at their adherence, most patients that were coming into their nursing homes were indeed being screened. Over time, despite the repeated visits by Becky at the different sites, the screen momentum had lost its edge, if you will. There were competing responsibilities, and the nursing staff or the newly screened staff wasn't just figuring out how to juggle the Torbest within all the other responsibilities that they needed to lead. But the speech-language pathologist, in this case Becky, kept up her visits, kept mentoring them, helped them problem solve, helped them realize that indeed the implementation of the Torbest was a time saver because it identified quickly patients who had swallowing problems, and all they needed to do then was refer on to a speech-language pathologist rather than troubleshoot at the bedside on how to deal with a choking patient. And what that led after the period of a year was a resurgence and an interest again to screen for dysphagia. So what this study tells us is sustainability really depends on the mentorship that's provided by the speech-language pathology department. So really critical what you do in the facility that you are working in how you mentor your colleagues to remember that dysphagia is a critical consequence of patients with stroke, and it can cause serious health issues like mortality and pneumonia. And simply screening will make a difference. This study was a study that, again, we were really proud of. It was a speech-language pathologist. This speech-language pathologist was from Brazil, Aline Pacheco Castillo. She's the first author of this study. She came and worked with us and did her PhD in our lab. And she was interested in the TORBEST for her stroke population in her country. And of course, the TORBEST is English. And in order to have it function within the Brazilian stroke population, it needed to be translated into Brazilian Portuguese. And so with her, as part of her PhD project, we did a very extensive translation where we did a literal translation and then a cultural adaptation of the TORBEST. And then we ran the translated Brazilian Portuguese TORBEST in a group of stroke patients in Brazil and determined the accuracy of this newly translated TORBEST. And we found it to perform with high accuracy, similar to the English TORBEST. We've since translated the TORBEST into several different other languages. We've got it in Japanese, in Chinese, in Italian, and Spanish, I believe, and French, of course, and French as well. So we're quite proud of the global outreach that the TORBEST has had, and the influence that a Canadian product was able to have on the world stroke stage. So dysphagia screening really is a Canadian success story. You know, I'm really proud of the fact that I was part of this story, but you should be too. I think the whole stroke speech language pathology community was really part of this story because we've all engaged, and many of us have engaged in these studies. You know, we started off this particular in our lab, we started off with a very careful design from the best evidence, adhering to principles of screening. You know, this was part of my PhD training. I knew what the science and how I was learning, and I executed the science based on these very scientific, rigorous methodologies. And these methodologies ensured that the science was executed in a way that the findings that we were generating had no error, had less bias error, and were increasingly applicable because we worked with the community to make sure that the way we were implementing this actually fit the clinical community. You know, we also got lucky. We aligned with the provincial and national stroke guidelines. So there was a national swell movement to care for stroke patients. And one of those facets of care was dysphagia. And so we were able to answer that call with the research that we were doing in our lab. So, and we also didn't just stop there. We've been studying the implementation and the uptake of dysphagia, not just in the acute stroke centers, but we went to the long-term care facilities. We were also in the community acute centers. So we really worked in the real world implementation of the TORBEST. And we haven't stopped, you know, we continue with our ongoing research. We have 3 studies now that are open, funded by CIHR, funded by Heart and Stroke, and another local group that's from the GTA, where we've got 3 trials right now where we're continuing to study the TORBEST. And I'll talk about one of those that's quite exciting and near the end of this talk that some of you might be involved in. So we've talked about the high risks value of having early identification for dysphagia. The Canadian, how we've as a country have really led the way. And then now let's talk about the value of bedside screening. If you remember before, my earlier slide suggested that it's just not just an accurate tool, but it has to have some proven benefit. And this was a study that one of my other doctoral students who was just about to defend Victoria Sherman had published, where she looked at data and compared findings from patients who were admitted to an acute stroke hospital, our hospital actually, the Toronto Western Hospital, using the TOR-BEST, which was a formal tool, versus informal identification of dysphagia. So not a tool per se, but some mention by a non-SLP that there might be a problem with the swallow. And what we found was interesting. These informal observations were all noted in the chart within 24 hours from admission. So this is good. You know, we have very strong clinicians working on our stroke ward who are very, you know, at that time were very attentive to dysphagia, even without a formal tool. But what was interesting was that the accuracy of those informal identifications of dysphagia was only 37.7% accurate. So we were missing a lot of patients with only informal capture of dysphagia presence. That changed when we used the TOR-BEST to have an accuracy of 96.3. So having a tool that can systematize the identification of dysphagia early is critical to maintaining the accuracy of that detection. Other work that we did, and this was with Raid Jundy, who's a stroke neurologist. He was with us doing his fellowship at the University Health Network, and he looked and benefited, I think, from the stroke database that we had been collecting over the years, and that was most populated in Ontario. So he used the Ontario Stroke Registry from April 2010 to 2013. And he enrolled over 7,000 patients. And what he looked at was the proportion of stroke patients who received dysphagia screening within 72 hours of arrival. And those who got screening, and then those who failed screening. And he looked at the outcomes of those patients. And what he found was that 80% of the patients who were eligible to receive dysphagia screening, in other words, the ones who were ready to have an oral diet, were indeed being screened within 72 hours. And of those that were not screened, the majority of those were mild stroke. So what was happening was the mild stroke somehow were not prioritized for screening. But what of those few mild stroke that were screened, what he found was that 33% of those had failed screening, failed dysphagia screening. So even though fewer mild stroke patients were screened, his study showed that mild stroke can still produce dysphagia and should indeed be prioritized for screening. This work, I was quite proud to be part of this, also showed that mortality is impacted for patients who fail versus those who pass screening. So here you see the whole group of patients, mild, moderate, and severe stroke, and the blue line signals those patients who passed screening, and the red line, those patients who failed screening. And you can see that those patients who failed screening had less likely to survive. So they were higher mortality. If we looked at the subgroup of only mild stroke patients, and you can see that the pattern is still the same there. Those patients who failed screening were more likely to die. The other piece to this work was also quite interesting, was that the patients with failed dysphagia screening had other outcomes that were also significant, and failed screening was associated with other poor outcomes such as pneumonia, severe disability, and discharge to long-term care. This is for the entire cohort of stroke patients and also for the mild sub-cohort. So again, dysphagia screening for all patients with stroke, those with mild strokes as well as those with severe stroke, is really, really critical. Another study that shows the timing of dysphagia screening is important is by Bray, and this comes to us from the UK. And here you have on the left are the time to dysphagia screen in hours. This is their whole sample, and this is eliminating patients who had cognitive issues. Here, again, they did the same thing, whole sample, and patients who had mild cognitive issues were eliminated. But, excuse me, here the x-axis is time to speech-language pathology assessment. So this is the gold standard assessment. This is the screen. And the y-axis is the incidence of stroke-associated pneumonia, so pneumonia. And the higher the line, the more likely the pneumonia. So you can see that the longer the delay from stroke to screen, the more likely their patients were going to get pneumonia, as well as the longer the delay from stroke to the SLP assessment, the more likely the patient would have pneumonia. So here, this really nice piece of work showed that the earlier we screen, the better the patient will fare. Now, as wonderful as this data was out there and was encouraging to me and others, there were other works that were contradicting this some. So we then decided, and it was Victoria Sherman, my doctoral student, and another doctoral student who was in the lab, Elisa Greco, who participated in this. We then decided to look at all of the literature and to determine systematically really what is the evidence telling us, not just the Bray study, but all the work collectively about the benefit of dysphagia screening to health outcomes in stroke. So we looked at over 8,000 papers, and we whittled it down to 21 articles that we analyzed that were eligible to answer this question. And there were some randomized controlled trials as well as observational trials. And the outcomes that we were looking for were pneumonia, mortality, and dependency and length of stay. And what we found here was, this is the forest plot. So just to give you a little bit of a lens to describe what this graph is telling you, is every line is one of the studies that we included. And we pooled their data to show benefit or not to, say in this case, pneumonia. And we pooled their data, and the data is represented here by little diamonds. The further the diamond is away from this vertical line, the more benefit the screen had to eliminating pneumonia. And what you see is the cluster of diamonds really all is to the left of the line, suggesting that as a pool of data, not all the individual studies, but overall, there was a strong support for screening to reduce pneumonia. So this is really nice empirical data that we hope to be included in the next round of the Canadian guidelines when they go up for renewal. And the good news gets only better, that not only did we see a benefit in pneumonia, reduced pneumonia in patients who were screened, but also in mortality and in dependency, just overall dependency, and length of stay. Now, admittedly, length of stay, the diamond is not that far off from that line, but it is on the left side. So the strength of the benefit is the greatest in pneumonia and in mortality. So good news. So what next? You know, we've identified that screening can be accurate. We've identified that screening can actually benefit health. What else do we need to work through? Well, we in our lab, and with some people probably on the call, and I will give you a shout out, so just hang on, are working on another study right now, and it's also a randomized controlled trial where we're looking at the training of the Torbest. We, as I said before, we've always relied on this 4-hour training live by a speech language pathologist because that was the way the initial trial was set up way back in 2000. But certainly the climate and culture has changed where a lot of our training now is online. So we thought that we would explore the accuracy and the ability, I guess, for us to shift the live training by a speech language pathologist to an online platform. And joining us on this one center in Alberta, in Red Deer, and the speech language pathologist there is Denise Sorensen. We have Sherry Darling, who's at the Toronto Western Hospital, who's really helping us from early days develop this trial. So she's been around for a long while, and we're really excited to be working with her as well. Lake Ridge Health, we have Connie Stamp and Amy McBray-Waller, who are working with us there. And we also are in Quebec with the Jewish General Hospital, and Gina Mills and her team are also helping us with that there. So this is early stages of this trial. We just got some funding to launch this, but this is a multi-site trial where we're going to compare the standard way of training our screeners using the 4-hour live SLP-led training, followed by the one-on-one live competency testing at the bedside. Compare that to 2 new models. And the 2 new models both include e-learning modules that the screener would go online and independently take, and then through a series of these modules take tests, and if they pass the tests, move on to the next module, and so on. There are 2 modules in total, and these e-learning modules will, if successful, would replace the 4-hour live SLP training. And the arm 2, we are also shifting up the competency check at the bedside. The arm 2 screeners will continue to be evaluated for their competency in determining and executing and interpreting the TORBEST by a speech language pathologist. But in arm 3, we're going to try something new, and it won't be a speech language pathologist now. It'll be a TORBEST competency mentor, a screener who's had a lot of experience screening and has sort of really become an expert in screening, to see how that fares as a mentor. And then, of course, we're going to compare the accuracy of the screeners in each of these groups. Those who used the traditional model, those who used the online, but with the SLP making the competency check, and those using the online, but a non-SLP doing the competency check. So that's the really exciting new study that we're just about to launch right now. So we're ready to go with the Toronto Western Hospital, and within the month, we hope. So in conclusion, I've described to you, what I think has been a wonderful demonstration of 3 Cochrane pillars, where we combined, the best research evidence, starting with, back in 2000, our first meta-analysis to derive what was missing. At that time, there was no tool. We developed a tool. We ensured that it was accurate. And then we've been assessing that tool in various different clinical environments to make sure that it still works, and ensuring that the implementation of that tool is maintained. And then we also included clinical expertise. I mean, I am a clinician. I practiced for 15 years, but I've collaborated in all of this work from the very first project with clinicians who are active in stroke, and that has kept this work really grounded and meaningful to the clinical community, and I'm really grateful for that. I think it really makes the rigor and the quality of this the best because of that collaboration. And together we've targeted what patients value. We've really targeted trying to address the health complications of patients with stroke and dysphagia, trying to reduce and mitigate against these unnecessary complications like pneumonia and mortality if it can be avoided. This is what this research is really intending to do. So it's quite exciting that these pillars have come together and really follow the principles of evidence-based practice. Full disclosure, this is really where, when I went back to do my PhD, this is where I did my PhD in this research world. And so to have my research really resonate in this way is really quite a privilege. And I'm really quite excited with this next project that is following the same format, collaborating very heavily with clinicians, and to see where that goes and where the next versions, perhaps, of the TORBEST training goes. So with that, I conclude, And thank you very much for your time. And I'm happy to take questions. And I'm sorry about the little hiccup with the internet.
So thank you very much, Dr. Martino. Yes, we apologize for the technical issues in the middle, not sure why, but very much appreciate your presentation. We do have one question for you, and it's from someone who's just saying, you know, during the pandemic, there are a lot of challenges of the ability to actually train in person for the Tour Best, and there are concerns that, you know, not enough people are trained. And just wondering if you have a sense of what others are doing while waiting for the online training to come. You know, how are sites managing during these times?
Yeah, thanks for the question. I mean, I think so much has had to be adapted because of the pandemic. I know clinical reality is completely different these days, but in fact, with the training and for screeners, we have, even before the pandemic, we've had several sites that have adapted because of geographical limitations. So, you know, Northern Ontario, certainly Northern Alberta, have done this, where they've trained, speech language pathologists have trained the screeners using the 4-hour modules that we provide using via telehealth, be it Zoom, or I guess at that time early on it was OTN, but now I think Zoom and Teams have become more available. So absolutely, the training would transfer, I think, quite comfortably to an online modality. Certainly, I've done online training using the Adobe connection that we use when we train SLPs to train screeners at various places. So I feel that is a useful and I would say successful way. Then what gets tricky is the live competency test. And there you need to then strategize a little bit on how that can be done. You can engage a local speech language pathologist to sort of be your ears and eyes, or you can, if there's permission, you can have a video of the session where the screener administers the Tour Best to a patient, and you are able to, with a camera, be able to view in. So that's where it gets a little bit tricky. But certainly the 4-hour training absolutely would be very conducive to a telehealth platform.
All right, thank you. Just given that we are at just past the 1 o'clock mark, I do think we will wrap up the webinar here. So, okay. Dr. Martino, I want to thank you again so much for taking the time today to present and to celebrate the Canadian success. So that was exciting.